I'm your host, Dr. Kohli, and today we're discussing a new kid on the block, a medication called Sotagliflozin, which is similar but different from its predecessors, medications called empagliflozin and dapagliflozin. And I'm so thrilled to be joined today by one of my favorite mentors, Dr. Deepak Bhatt. Dr. Bhatt is the director of the Mount Sinai Fuster Heart Hospital and the Valentin Fuster Professor of Cardiovascular Medicine at Mount Sinai. Now, if that's not enough, he's also the PI and senior author of the landmark trials on sotagliflozin. In addition to that, he's one of the nicest people that I know. Welcome, Deepak.
Great to be with you.
So, Deepak, over the last several years, we have all become very familiar with SGLT2 inhibitors. I know I've been using them in heart failure, diabetes, and chronic kidney disease, but now there's a different type of a medication, which is an SGLT1 and SGLT2 inhibitor, and that's this medication called sotagliflozin. So I wanted to take a couple of minutes and pick your brain about what are the key differences between sotagliflozin and prior medicines like empagliflozin or dapagliflozin, and how does that SGLT1 inhibition really sort of change the pathophysiology of the medication?
Great question. So sotagliflozin is a dual SGLT1 and SGLT2 inhibitor. So it has all the benefits of SGLT2 inhibition that at this point in time, most people are very familiar with, a mechanism of action that's primarily in the kidney and the proximal convoluted tubule. So that's the SGLT2 inhibition in the kidney, lots of good benefits in terms of heart failure outcomes, in terms of kidney outcomes. Sotagliflozin additionally inhibits the SGLT1 receptor. So that is the primary transporter for absorption of glucose and galactose in the GI tract. So SGLT2 is working in the kidney to prevent reabsorption of glucose, and SGLT1 is working in the gut. And by inhibiting SGLT1, it's a kidney-independent way of slowing down glucose transit time and therefore improving the glycemic profile over the course, say, of 24 hours. And SGLT1 is expressed in other organs in the as well in the body, heart and brain. The exact significance is still being elucidated. So bottom line is the SGLT1 is doing extra stuff beyond the SGLT2.
And what's fascinating is that in certain disease states, we get upregulation, as you know, of SGLT1 and SGLT2 in many of these organs. So I'm curious, based on what you just described, would you consider this sort of a different class of a medication, or would you consider it some of the same in terms of the physiologic effects with SGLT2 inhibitors?
Well, in many sort of meta-analyses, it gets lumped in with the SGLT2 inhibitors, and it certainly has benefits, say, on the kidney, that are similar to other SGLT2 inhibitors. It, for example, slows progression of albuminuria, in some cases even leads to regression of albuminuria. So kidney protective effects that are probably from the SGLT2 inhibition. But in addition, it lowers rates of heart failure-related events. That's been seen in the SGLT2 inhibitor trials too. Now, the magnitude of effect was particularly large. If we talk about the Soloist trial, for example, that was acute decompensated heart failure patients, and once they were stabilized, they were randomized to sotagliflozin or placebo, and there was a really large benefit, both in relative terms, but even in absolute terms. A number needed to treat of just 4 patients for a year, so that's a really low number to treat for any part of medicine or cardiovascular medicine. Now, is that the sotagliflozin with the SGLT1 beyond the SGLT2? Is it that we picked a really high-risk population? One can debate those points, but nonetheless, a really large risk reduction beyond that seen with other drugs in this broad class in other trials. So that's one potential issue in terms of differentiation. The other, and this is a clear area of differentiation, is the effect on MACE, major adverse cardiovascular events, where in the SCORED trial, which was stable patients with diabetes with cardiovascular risk that's enhanced, their randomization to sotagliflozin in that stable patient population also significantly reduced heart failure-related events, but also significantly reduced myocardial infarction and stroke. And if you talk about the other SGLT2 inhibitors, kind of mixed signals on MI, and none have shown a significant reduction in stroke. So here we have the ability with sotagliflozin to affect heart failure-related events, kidney-related events, and unlike the other agents, a clear effect on MACE, including stroke.
You know what? I want to draw out a couple of things that you said because there's so much in there. So it's really a mic drop moment when it comes to a number needed to treat of 4. And those are numbers that we have not seen with many of the other agents. In fact, many of the other medications that we use in cardiology. So to me, that's a really sort of dramatic impact on reducing morbidity and mortality in this particular population. The other thing that you said that I thought was really interesting is that you started this in patients during the hospitalization. And often when patients come in with heart failure, they have AKI, they've got decompensated heart failure. We worry really a lot about starting these types of medications. But what this trial showed us, in fact, is that not only is it safe, but it actually is a good idea to start them early up front during that hospitalization once they've sort of stabilized from the heart failure perspective, because the number needed to treat is so low and because those curves actually separate very early, less than a month, right?
Oh, absolutely. It's early separation of the curves. As you said, by about a month or so, things are statistically significant in the soloist trial. It's kind of interesting since you're talking about curves and separation and so forth. In the SCORE trial, again, these are stable outpatients. The curves separated early as well there for heart failure, but even for MACE, it separated by about 3 months and was significant at that point, which you wouldn't necessarily in a stable population. This isn't even an ACS population. It's a stable population. You wouldn't necessarily expect such a quick, not only heart failure benefit, but also MACE benefit. So I think the idea of starting this therapy as soon as possible in the case of heart failure patients in the hospital, but once they're stabilized, as you rightly point out, was safe, but also highly efficacious.
And it's really interesting, as you said, that we have receptors for SGLT1 in the brain, and we're seeing positive benefits on stroke as well. Now, I want to talk to you a little bit about the doses, because here this agent is also different from other agents where there's a target dose for AMPA and DAPA. You get to 10 milligrams or so for heart failure. Talk to me a little bit about the 2 doses of sotagliflozin. How do you choose the doses? And in SOLOIST and SCORED, in fact, both doses were used. But how did you decide who you get which patient on? Is there target dose? What is your clinical practice like?
Sure. So within the trials, patients were titrated up from 200 to 400 milligrams, and the majority of patients got titrated up unless they had perceived side effects, things like hypotension and so forth, where it might have made sense then not to titrate a drug up. But interestingly, the rate of non-titration was the same between placebo and the drug. So, in those cases of non-titration, the doctor, of course, the investigator was blinded, was thinking, oh, there's a potential side effect from the experimental medicine, but no, it was the same in the placebo arm. So in fact, it could have been up titrated just fine. And, the benefits were quite significant with the 200 milligrams. Those who were up titrated at 400 milligrams actually had even larger degrees of benefit, as it turned out. Some of that, of course, in these sorts of analyses, could be a little confounded because if you up titrate any medicine, that's usually sort of an idealized patient and they're not having side effects, tend to have better outcomes. But even putting aside that potential for confounding, it did seem like you got a little bit more bang for your buck, so to speak, at the 400 milligrams in the trial.
Great. Do I have more side effects as a patient because I have dual SGLT1 and SGLT2 inhibition?
That's a terrific question. And no, in terms of the SGLT2 part, the SGLT1 does cause a slight increase in diarrhea, as one would expect from just, what's happening in terms of glucose handling in the gut. So that's something to be aware of. But in absolute terms, the rates went up from like 4% in the placebo arm to like 6% in the treated arm. So the absolute increase was actually rather small. And in terms of badness associated with the diarrhea, people getting hypovolemic, kidney failure, hospitalization for that sort of thing, hypotension, that really didn't seem to be an issue as far as bad side effects. So something to be aware of, but really in terms of the overall safety profile, very, very similar to other SGLT2 inhibitors.
Well, I'm excited about using this drug in my patients, but before I let you go, I want to ask you a last question. We talked about a lot of data today, but as a PI of these incredible landmark trials and, as this new in class agent, what is the most interesting thing to you about this particular drug?
I would say it's a word that sometimes is thrown around out there. It's pleiotropic mechanism of action because there's, we don't have time to get into all the basic science now, but there's a lot of evolving basic science about sotagliflozin, effects it has, effects that are different from other drugs in the sort of broader SGLT2 inhibitor class. And I think the ability to influence heart failure, kidney, and MACE outcomes with one drug, but working through, at least a couple of different pathways is truly remarkable. And my hope is we'll learn more about this compound in the years to come from further research, and that'll show us just how it could be really clinically useful in a variety of different settings beyond the ones in which it was studied and soloist and scored.
Well, Deepak, this has been a really fascinating discussion, and I've been so excited to hear your perspective because you were really at the forefront of all of this groundbreaking research. I know personally, I can't wait to start using it in many of my patients. And, I hope that this has now added another tool in our toolbox to already the great advances that we've made in management of our patients with heart failure and with chronic kidney disease. So I want to thank you for joining me today, and I want to thank our audience for joining us as well. Thank you, Dr. Bhatt, and until next time.